Hello everyone, today here is RN Osama. We'll speak about the intramuscular injection in this lecture. I'll speak about how we administer the medication in the ventrogluteal site, the deltoid site, and the vastus lateralis site. So we need first, what are the intramuscular injection and what does this mean? The intramuscular injection meaning deposit of the medication into the muscle fascia, which has a rich blood supply, allowing the medication to be absorbed faster through the muscle fibers than they are through the subcutaneous route. The intramuscular site is used for the medication that requires a quick absorption rate but also a reasonably prolonged action. Due to their rich blood supply, the IM injection sites can absorb larger volumes of the solution, which means a range of the medications such as sedatives, antiemetics, hormonal therapies, analgesics, and immunization can be administered intramuscularly in the community and acute care setting. In addition, muscle tissue is less sensitive than the subcutaneous tissue to irritating solutions and concentrated and viscous medication. The technique of intramuscular injection has changed over the past years due to the evidence-based research and the change in the equipment available for this procedure. The intramuscular site is chosen based on the age and condition of the patient and the volume and type of the medication injected. When choosing a needle size, the weight of the patient, age, amount of the adipose tissue available, the medication viscosity, and the injection site all influence the needle selection. Intramuscular injections must be done carefully to avoid complications. Complications with intramuscular include muscle atrophy, injury to the bone, cellulitis, sterile abscesses, pain, and nerve injury. With intramuscular injections, there is an increased risk of injecting the medication directly into the patient's bloodstream. In addition, any factors that impair the blood flow to the local tissue will affect the rate and extent of the drug absorption. Because of the adverse and the documented effect of the pain associated with intramuscular injections, always use this route of administration as a last alternative. Consider other methods. The sites for the intramuscular injection include the ventrogluteal, the vastus lateralis, and the deltoid site. In this literature, this shows the inconsistency in the selection of the sites for deep muscular injections. Selection may be based on the familiarity and confidence rather than on the best practice. However, there is sufficient evidence that the ventrogluteal muscle site is the preferred site whenever possible and is an acceptable site for oily and rotating medications. The ventrogluteal site is free from blood vessels and nerves and has the greatest thickness of the muscle when compared to other sites. A longer needle with a larger gauge is required to penetrate the deep muscle tissue. The needle is inserted at a 90-degree angle, perpendicular to the patient's body, or at a close to a 90-degree angle as possible. Use a quick darting motion when inserting the needle. Aspiration. Aspiration refers to the action of pulling back on the plunger for 5 seconds prior to the injecting of the medication. Current practice in the acute care setting is to aspirate intramuscular injections to check for blood return in the serum. Lack of blood return in the serum confirms that the needle is in the muscle and not found in a blood vessel. If the blood is aspirated, remove the needle, discard it appropriately, and re-prepare another one and administer the medication. Recent research has found that there is no evidence to support the practice of aspiration, but despite policy changes, the procedure of aspiration continues to be taught and practiced. Vaccination and immunization given by intramuscular route injection are never to aspirate in this. We'll then speak about the Z-track method. The Z-track method is a method of administering the medication in the muscle and prevent the medication to go to the subcutaneous route. So an IM injection that prevents the medication being tracked through the subcutaneous tissue, sealing the medication in the muscle and minimizing the irritation from the medication. Using the Z-track technique, the skin is pulled laterally away from the injection site before the injection. Then the medication is injected. The needle is withdrawn and the skin is released. This method can be used if the overlying tissue can be displaced. At the next tables, we will speak about every site and the additional information related to the site. So we'll speak first about the ventrogluteal site. As you see in this image, we see that the nurse putting her heel of the hand over the greater trochanter and her index referring to the anterior superior iliac spine and her middle finger referring to the iliac crest, and between the two fingers, the index and the middle finger, there is a V-shaped where the injection site. Consider this. So the site involves the gluteus medius and the minimus muscle and is the safest injection site for adults and children. The site provides the greatest thickness available of the gluteal muscles and is free from penetrating the nerves and blood vessels and has a thin layer of fat. To locate the ventrogluteal site, place the patients in the supine or lateral position, meaning on their side. The right hand is used for the right hip and the left hand is used for the right hip. Place the heel or the palm of your hand on the greater trochanter with the thumb pointing towards the belly button. Extend your index finger to the anterior superior iliac spine and spread your middle finger pointing towards the iliac crest. Insert the needle into the V formed between your index and middle fingers. This is the preferred site for all oily and irritating solution for the patients of any ache. Needle gauge is determined by the solution. An aqueous solution can be given with a 20 to 25 gauge needle. Viscous or oil-based solution can be given with 18 to 21 gauge needles. The needle length is based on the patient weight and body mass index. A thin adult may require a 16 mm to 25 mm or 5/8 to 1 inch needle, while an average adult may require a 25 mm or 1 inch needle. And a larger adult over the 70 kilograms may require a 25 mm to 38 mm, meaning 1 to 1.5 of the inch needle. Children and infants will require shorter needles. Refer to the agency policy regarding the needle length for infants, children, and adolescents. For the ventrogluteal muscle of an average adult, give up to 3 milliliters of the medication at every shot you give. This is the maximum. Then we will speak about the vastus lateralis, and as you see in the next image, we see the thigh and the lateral of it. We see that the dart is referring to the vastus lateralis, which is the outer middle third, and this is the injection site. And to the medial, to the body, we see the rectus femoris. This is another injection site, but we will not speak about in this lecture. We see the greater trochanter and the lateral condyle of the femur. Next, the vastus lateralis is commonly used for immunization in children from infants through to toddlers. The muscle is thick and well developed. This muscle is located on the anterior lateral aspect of the thigh and extends from one hand's breadth above the knee to one hand's breadth below the greater trochanter. The middle third of the muscle is used for the injection. The width of the muscle used extends from the midline of the thigh to the midline of the outer thigh to help relax the patient. Ask the patient to lie flat with the knee slightly bent, or have the patient in the sitting position. The length of the needle is based on the patient's age, weight, and body mass index. In general, the recommended needle length for an adult is 25 mm to 38 mm, meaning 1 to 1.5 of the inch. The gauge of the needle is determined by the type of the medication administered. Aqueous solution can be given with a 20 to 25 gauge needles. Oily or viscous medication should be administered with 18 to 21 gauge needles. A smaller gauge needle between 22 to 25 gauge, we use this type of the needles, should be used with the children. The length will be shorter for infants and children. See your agency policy. The maximum amount of the medication for a single injection is 3 milliliter. Then we will speak about the deltoid muscle and the additional information for the deltoid muscle. The deltoid muscle has a triangle shape and is easy to locate and access, but is commonly underdeveloped in adults. Begin by having the patient relax the arm. The patient can be standing, sitting, or lying down. To locate the landmark for the deltoid muscle, expose the upper arm and find the acromion process. By palpating the bony prominence, the injection site is in the middle of the deltoid muscle, about 2.5 to 5 centimeters, meaning 1 to 2 inches below the acromion process. To locate this area, lay 3 fingers across the deltoid muscle and below the acromion process. The injection site is generally 3 fingers width below in the middle of the muscle. Select the needle length based on the age, weight, and body mass index. In general, for an adult male weighing between 60 to 118 kilograms, we use a 25 millimeter or 1 inch needle is sufficient for this. For women under 60 kilograms, a 16 millimeter or 5/8 inch needle is sufficient, while for a woman between 60 and 90 kilograms, a 25 millimeter or 1 inch needle is required. A 38 millimeter or 1.5 of the inch length needle may be required for women over the 90 kilograms for a deltoid IM injection. Refer to agency policy regarding specification for infants, children, adolescents, and immunizations. The maximum amount of the medication for a single injection is generally 1 milliliter at the deltoid muscle. For immunization, a smaller 22 to 25 gauge needle should be used. As you see in the next two images, you see on the left the green triangle. This is the safe injection site at the deltoid site. We see the scapula, the deltoid muscle, the acromion process, the clavicle, the injection site. We see the axilla, the humerus, the radial nerve, the deep brachial artery, and we should take careful of the radial nerve because these nerves are very important to the body. And we see on the right that the nurse is landmarking the site of the deltoid to inject the medication. Then we have special consideration to taken before we start. We need to avoid muscles that are emaciated or atrophied. They will absorb the medications poorly. Then, intramuscular injection sites should be rotated to decrease the risk of hypertrophy. Older adults and same patients may only tolerate up to 2 milliliter of the medication in a single injection. Choose a site that is free from pain, infection, abrasions, or necrosis. The dorsogluteal site should be avoided for intramuscular injections. If a needle hits the sciatic nerve, the patient may experience partial or permanent paralysis of the leg. And we consider the type of the medication and the age of the patient, the condition of the patient, and the size of the patient when selecting an intramuscular site. We rotate the intramuscular sites to avoid complications. Potential complications include the lingering pain, tissue necrosis, abscesses, and injury to the blood vessels, bones, or nerves. If administering a vaccination, always refer to the vaccination guidelines for the site selection. As a first, we'll speak about the number 1 checklist and the steps to perform intramuscular injection. And we need to see the disclaimer and always review and follow your hospital policy regarding this specific skill. And take this safety consideration. Ensure that the patient's position for the injection is not contraindicated by a medical condition or case, like circulatory shock or surgery. And always wear gloves to administer the injections. Although policy may vary from place to place, the CDC recommends wearing gloves if there is a potential for contact with blood or body fluids. If required by the agency policy, aspirate for blood prior to administering the medication in the muscle. Open the injection if a patient complains of a radiating pain or a burning sensation or tingling sensation. Remove the needle and discard it, because there is a possibility that you hit the nerve. Take all necessary steps to avoid the interruption and distraction when preparing and administering the medication. If a patient expresses concern and question during the procedure, always stop and explore the patient's concerns by verifying the order. Never recap the needle after giving an injection. Apply the safety shield and dispose it in the closest sharp container. In the next procedure, this is the procedure we will speak about the steps at the left, and we'll tell you the rationale at the right or additional information. First, we perform assessment. We perform hand hygiene. This hand hygiene prevents the spread of microorganisms. As you see in the next image, hand hygiene with alcohol-based hand rub. The second step, compare the medication administration record to the patient wristband and use two patient's identifiers to confirm the patient. The rationale for this is that using two identifiers improves the medication safety by ensuring that you have selected the corrected patient. As you see in the next image, compare the medication administering record to the patient's wristband. Number 3. Assess the patient's symptoms, knowledge of the medication to be received, history of allergies, drug allergies, and types of allergic reactions. Because assess patients' data such as vital signs, laboratory values, and allergies before preparing and administering the medication by injection is very important. This consider a pre-assessment. Number 4, assess for any factors that may contraindicate the intramuscular injection. Factors to look for include circulatory shock, surgery, or muscle atrophy. Then the preparation. We verify the practitioner or healthcare order and the medication administration record. And we compare the physician orders and the medication administering record. Number 6. We review the medication information such as the purpose of the medication, the actions, the side effects, normal dose and rate of the administration, the time of onset, the peak and the duration, and the nursing implications. Because knowledge of the medication ensures the correct patient receives the correct dose of the medication at the correct time via the correct route for the correct reason using the correct documentation. Number 7. Assemble the supplies and prepare the equipment. Assemble medications, non-sterile gloves, alcohol swabs, syringes, needles, and sharp containers. Number 8. Prepare the medication from an ampoule or vial as a pre-hospital policy. Always compare the medication administering record to the practitioner's original orders to ensure accuracy and completeness. This prevents the medication errors by providing additional check. And this image referring to the pre-medication from a vial. Number 9. Never leave the medication unsupervised once prepared. Medication left unattended may lead to medication errors. We will go to the procedure. Number 10. Perform hand hygiene. Hand hygiene prevents the transmission of microorganisms, as we said. Hand hygiene with alcohol-based hand rub, as you see in the next image. Number 11. Close the curtains or doors. This creates and maintains the patient's privacy. Number 12. Verify the patient using the two unique identifiers and compare to the medication administering record. This step confirms the correct identity of the patient. Compare the medication administering record to the patient's wristband. Number 13. Explain the procedure and the medication and give the patient time to ask questions, and you need and must answer the patient questions. Knowing what is happening helps minimizing patients' anxiety. Let the patient know that there may be mild burning at the injection site. Number 14. Don non-sterile gloves and prepare the patient in the correct position. Ensure that the sharp disposable container is close by for disposal of the needle after administration. This prepares the patient for the injection, as you see in the next image, ensuring that the sharp container is closed by allowing for a safe disposal of the needle. Number 15. Locate the correct site using the landmarks and clean the area using alcohol and antiseptic swabs. Allow the site to dry completely. Allowing the site to dry prevents the stinging during the injection. Number 16. Place a clean swab or dry gauze between your third and fourth finger. This allows for easy access to dry gauze after injection. This is a gauze between the fingers 3 and 4. Number 17. Remove the needle cap by pulling it straight off the needle. Hold the syringe between the thumb and the forefinger on the dominant hand as if holding it as a dart. This prevents the needle from touching the side of the cap and prevents contamination of the needle. As you see in the next image, we pull cap of the needle. Number 18. With the non-dominant hand, hold the skin around the injection site. This secures the area for the injection. Number 19. With the dominant hand, inject the needle quickly into the muscle at a 90-degree angle, using a steady and a smooth motion. Insert the needle with a dart-like motion, as you see in the next image. Number 20. After the needle pierces the skin, use the thumb and the forefinger of the non-dominant hand to hold the syringe. Movement of the needle once injected can cause additional discomfort for the patient. Insert the needle with a dart-like motion, as you see in the image. Number 21. If required by agency policy, aspirate for blood. If no blood appears, inject the medication slowly and steadily. If blood appears, discard the syringe and the needle and prepare the medication again in a new syringe. Because the injection sites recommended for the immunization don't contain large blood vessels, aspiration is not necessary when immunization. As you see in the image, aspiration of the plunger for blood return check. Number 22. Once the medication is completely injected, remove the needle using a smooth, steady motion. Remove the needle at the same angle at which it was inserted. Using a smooth motion prevents any unnecessary pain to the patient. Number 23. Cover the injection site using the sterile gauze between your 3 and 4 finger. Using a gentle pressure and apply a band-aid as required. Covering prevents the infection at the injection site. As you see, we cover the injection site. Number 24. We place a safety shield on the needle and discard the syringe in the appropriate sharps container. Placing the sharps in the appropriate puncture-proof and leak-proof receptacles prevents accidental needle stick injury, as you see in the image that disposes of the syringe in the sharp containers. Number 25. Discard the supplies, remove the gloves, and perform hand hygiene. This step prevents the spread of microorganisms and protects you and the patient. Hand hygiene with alcohol-based hand rub, as you see in the image. Number 26. Document the procedure as a pre-agency policy. Document of the medication, the time, the route, the site, the date of administration, and the effect of the medication, any adverse effects, unexpected outcomes, and any interventions applied. Number 27. Assess the patient's response to the medication after the appropriate time frame. Because assessing for the effectiveness of the medication, like the onset, peak, and the duration, assess the injection site for pain, bruising, burning, or tingling is very important. At the next checklist, number 2, we will speak about the injection and performing a Z-track during the injection. And important disclaimer: always review and follow your hospital policy regarding this specific skill. and it takes these safety considerations, ensures that the patient's position for the injection is not contraindicated by a medical cause or case, like circulatory shock or surgery, and always wear gloves to administer the injection. Although policy may vary, for example, if you are in an acute setting compared to a community setting. The CDC recommends wearing gloves if there is potential for contact with blood or body fluids. If required by agency policy, aspirate for blood prior to administering an intramuscular medication. Open injection. If a patient complains of radiating pain or burning sensation or tingling sensation at the area of the injection, remove the needle and discard it because there is a potential that you hit the nerve supply the area. Take all necessary steps to avoid interruption and distractions when preparing and administering the medication. If a patient expresses concern or questions the medication, always stop and explore the patient's concerns by verifying the order and answer the patient. Never recap the needles after giving an injection. Apply the safety shield and dispose it in the closest sharps container. And then we will speak about the procedure. First, we do some assessment like perform hand hygiene. Hand hygiene prevents the spread of microorganisms, as we said, and we use the alcohol-based hand rub. Number 2, we compare the medication administering record to the patient's wristband and use the 2 patient identifiers to confirm the patient that we give the correct patient the correct medication. And number 3, we assess the patient's symptoms, knowledge of the medication to be received, history of allergies, drug allergies, and the type of the allergic reaction. Because assess the patient's data such as vital signs, laboratory values, and allergies before preparing and administering the medication by injection is very important. Number 4, assess for any factors that may contraindicate the injection that will be occur. Factors to look for include circulatory shock, surgery, or muscle atrophy. Then we do the preparation. Number 5, we verify the practitioner order and the medication administration record. And as you see in the image, we verify the physician order on the medication administering record. Number 6, we review the medication information such as the purpose, action, side effects, and normal dose and rate of administering and time of onset, peak, and the duration and the nursing implication of everything we do. Knowledge of the medication ensures the correct patient receives the correct dose of the correct medication at the correct time via the correct route for the correct reason using the correct documentation. Verify expiry date of the medication and check for the particulates and discoloration or loss of integrity or the sterility of the medication. Discolored or outdated medication may be harmful to the patient. If a medication is discolored or cloudy, always check the manufacturer's specifications for the medication. Number 8, assemble the supplies. Because a symbol of the medication supplies like the non-sterile gloves, the syringe, needle, and sharp container is very important to ease the process of the procedure. Number 9, prepare the medication from an ampoule or a vial as a bare hospital policy. Always compare the medication administering record to the practitioner's original orders to ensure accuracy and completeness. This prevents the medication errors by providing an additional checks. As you see in the image, we prepare the intramuscular injection from the vial. Number 10, never leave the medication unsupervised once prepared. Unsupervised medication may lead to medication errors. We will then get in the procedure. Number 11, perform hand hygiene. Number 12, close curtains or doors that maintain the patient's privacy. Number 13, verify the patient using the 2 unique identifiers and compare to the medication administering record. This confirms the correct identity of the patient. Follow policy for safe medication administration. As you see in the image, we compare the identification and allergic band with the medication administering record. Number 14, we explain the procedure and ensure that the medication is correct, and we give the patient the time to ask questions and we need to answer the patient's question. Knowing what is happening helps minimize patient anxiety. Let the patient know there may be mild burning at the injection site. Number 15. Don non-sterile gloves and select the correct site of the injection and prepare the patient in the correct position. Ensure a sharp disposable container is close by for disposal of the needle after administering of the medication. This prepares the patient for injection, ensuring that the sharps container is close by allow for safe disposal of the needle and sharps items. Number 16. Locate the correct site using the landmarks and clean the area with alcohol or antiseptic swab. Allow the site to dry completely. Allowing the site to dry prevents the stinging during the injection. Number 17. Place a clean swab or dry gauze between your third and fourth fingers. This allows for easy access to the dry gauze after the injection. Number 18. Remove the needle cap by pulling it straight off the needle. Hold the syringe between the thumb and the forefinger on the dominant hand, as if holding as a dart. This prevents the needle from touching the side of the cap and prevents contamination. As you see in the image, we pull the cap of the needle straight off. Number 19. Displace the skin in a Z-track manner by pulling the skin down or to one side about 2 centimeters or 1 inch with your non-dominant hand. And the rationale for this is that the Z-track method creates a zigzag path to prevent the medication from leaking into the subcutaneous tissue. This method may be used for all medication injection or may be specified by the medication. As you see in the image, the nurse pulls the skin laterally to the injection, and we pull or push the skin 2 to 3 centimeters away from the injection site with the non-dominant hand. Number 20. With the skin held to one side, quickly insert the needle at a 90-degree angle. After the needle pierces the skin, continue pulling on the skin with the non-dominant hand, and at the same time, grasp the lower end of the syringe barrel with the fingers of the non-dominant hand to stabilize it, and move the dominant hand to the end of the blanket. If required by ANC policy, the aspiration procedure, aspirate for blood. If no blood appears, inject the medication slowly. The rationale for this is that insert the needle with a dart-like motion. A quick injection is less painful. Inject the medication at 10 seconds per milliliter. Because the injection sites recommended for the immunization don't contain large blood vessels, aspiration is not necessary when immunization. As you see in the image, after cleaning the skin site, we inject the needle into the tissue at a 90-degree angle and aspirate for blood return. If no blood return, we slowly inject the medication. Number 21. Once the medication is given, leave the needle in the place for 10 seconds and avoid moving the syringe. The rationale for this is that leaving the needle in place allows the medication to be displaced. Movement of the needle can cause additional discomfort for the patient. Number 22. Once the medication is completely injected, remove the needle using a smooth, steady motion, then release the skin. The rationale for this is that using a smooth motion prevents any unnecessary pain to the patient. Withdraw the needle, then release the skin. The injection tract seal as the skin is released. Skin, subcutaneous tissue, and muscle, as you see in the next image. Number 23. Cover the injection site with a sterile gauze using the gentle pressure and apply a band-aid as required. Don't massage the site. Covering prevents the infection at the injection site. As you see in the image, we cover the injection site with a sterile gauze. Number 24. We place a safety shield or needle guard on the needle and discard the syringe in the appropriate sharps container. Placing the sharps in the appropriate puncture-proof and leak-proof receptacles prevents the accidental needle stick injuries. Dispose of the syringe in the sharps container as you see in the image. Number 25. We discard the supplies, remove the gloves, and perform hand hygiene. This step prevents the spread of microorganisms, and we using it to clean the hand, the alcohol-based hand rub. Number 26. Document the procedure as per agency policy. Document the medication, time, route, site, date of administration, and the effects of the medication, and any adverse effects, any unexpected outcomes, and any interventions applied. Number 27. Assess patient's response to the medication after the appropriate time frame. Assess for effectiveness of the medication, onset, peak, and duration. Assess the injection site for pain, bruising, burning, or tingling. At the next 3 slides, there are 3 videos speaking differently over each method we speak today. And you will find the 3 videos speaking about the intramuscular injection in the deltoid site, in the vastus lateralis, and in the ventrogluteal site. And I hope that this lecture makes you know everything about the intramuscular injection, and thank you.
Hi Renee, so we're going to be doing landmarking of a deltoid and administering an IM injection using Z-Track.
Yes.
Okay.
Okay. So I've prepared my medication. I've brought my MAR and my med to the bedside. Sir, can you tell me your name and your birth date?
Ross Geller, March 3rd, 1999.
Awesome. So I have your morphine for you. It's for pain. Okay, you've had it before, right? Do you have any allergies? No. Okay. So Ross has a really good deltoid muscle in terms of mass, and so this will be a good choice for an injection for him. I need to landmark to make sure I'm getting it into the right place. So I can find an acromion process. I can go 3 finger widths down, and then I always do this poke test to make sure that I have enough
That
meat.
sweet spot, eh?
Yeah. Another way to landmark is to find the axilla crease, draw a line, and then draw a triangle from that acromion process. And again, you're right in the center. And you have a third way.
Oh yeah, you just sort of run your finger up into the armpit, lay your hand down, and you'll have the V, and then you're just 2 down there. So right there. Same. So it all comes the same place.
We've all arrived to the same place. So I've done some hand hygiene. I've made a choice to wear gloves. I'm going to clean my site from the inside out. The literature is inconsistent about how long you should clean the site for, but what's very consistent is that you have to let the alcohol dry. It doesn't have antiseptic properties if it's still wet.
Okay.
Okay, so I'm going to just do one last check on my med before I give this to him. Okay, so now we have to Z-Track. So Z-Track is a method of just trying to displace the top tissue layers so that the medication's not going to leak out afterwards. And it's really pretty straightforward. You just have to slightly move the skin. So Z-Track, stab. Actually, I'm going to go Z-Track, stab, grab, aspirate, inject.
Okay. So do that once more.
Okay. Z-Track, stab, grab, aspirate, inject.
And how fast do we inject in?
It kind of depends on the medication. It can hurt when you're trying to put a volume into a muscle. Some medications are more painful than others. So this being 1/2 ml, I would say you could probably have that injected in about 10 seconds.
Okay. What if the patient says, oh, ow, 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 ow?
Then slow down.
Okay.
Yeah, and you can use distraction techniques like tap your foot on the floor, or start singing a song, or wiggle the fingers on your other hand, something just to get their mind off.
Okay.
Yeah. The other thing is if we aspirate and we get blood, because that's part of the risk with IM injections, we need to remove the needle and go start the whole process again.
Okay. So we're going to do another IM, but using another site. What's this one called?
This one's called ventrogluteal. It's the
Okay.
side, the muscle on the side of your hip.
Okay.
Yeah.
We used to do dorsal gluteal. Do we do that one anymore?
Yeah, way back in the day. So now we're aging ourselves.
Yes.
We used to do dorsal gluteal all the time, but there's too many nerves and too many blood vessels in that site, and there's been too many injuries, and as such, it's been removed from all of the procedure manuals.
Okay, so
Yeah.
it's always ventral gluteal.
Yep.
Okay.
Okay, so I've prepared my medication. I have my MAR at my bedside. Can you tell me your name and birth date, please?
Ross Geller, March 3rd, 1999.
Awesome. So I have your morphine for you, Ross, okay? And I'm going to put it into your hip. All right, and I've checked his ID band at the same time.
Okay.
So this time we just need to expose him a little bit. My landmarks this time are greater trochanter, the anterior superior iliac crest. I'm going to put the heel of my hand onto that greater trochanter. I'm going to point my thumb towards the groin, my index finger towards that ASIS, and I'm going to make a V. And I'm going to do a poke test. Now, depending on the size of your hand, I like the feel of this better than this.
Yeah, because this is very hard.
Yeah.
It's just,
so anatomically, we're all kind of the same, but we're all a little bit different too. So that's why I suggest to students always do that poke test. So I'm going to take my alcohol swab. Okay. And I'm going to clean that site. Again, from the inside out. Leave my corner poking to where I need it to be. Okay, Z track this time. Just a little bit of a displacement. Stab, grab, aspirate, inject.
okay.
And then pull up.
So is there a sequence, like when you go to pull out, can you let go of your Z track? Or do you do it all at the same time?
Really good question. I haven't given an IM injection for a long time because they are sort of fading away. That where we see IM injections most of the time is in flu clinics, but flu clinics don't Z track. And in flu clinics, or anytime they give immunizations, they don't aspirate because there's a different body of research. I think aspiration is one of those controversial things right now that we may see go the way of the dodo bird in the future, because even the literature is inconsistent on whether or not we should be aspirating.
Yeah.
What do you do in your practice? Do you let the Z go?
Yes, you can let the Z go because you've pulled it over and you've got the needle in it. So when you push it back, as soon as you're pulling out, the tissue will move over.
Yeah.
So the whole thing is to think of the needle going down as a well.
Right.
And the tissue will move back over top of it. So that's okay to do that.
Okay, great.
So IM injections.
Right, into the vastus lateralis,
Okay,
so being a leg muscle.
Why would we choose this and not the deltoid?
If I need a larger volume, I can put a larger volume into vastus lateralis, generally.
Yeah, because
But
deltoid is on what, 2
up
mil?
to 2 mils, although if somebody has a large muscle mass, you might decide to go for 3. It's really up to the nurse to make that judgment every time they go to the bedside. As you know, you can have an adult that weighs 100 pounds and one that weighs 300 pounds. So you use that accordingly. You wouldn't put 3 mils of fluid into somebody with a little emaciated muscle.
Yes.
Yeah. Okay, so we're going to do vastus lateralis. So I've prepared my medication. I have my MAR at the bedside. Can you please tell me your name and your birth date?
Ross Geller, March 3rd, 1999.
Awesome. So I have your morphine for you. It's for pain. Okay. All right, so I'm going to put it in your leg. So if you can relax your leg muscle, I think it'll be more comfortable. In terms of landmarking, I look about where the knee is and landmark there. I think about the greater trochanter and I landmark there. And I'm going to go in the middle third of the muscle, which will be here. Okay, so I'm going to use my alcohol swab, clean from the inside out. And now this time we can leave the corner of the alcohol swab pointing to where I want to actually do the injection.
That's handy.
Yeah. Okay, so now I'm going to Z track again. So again, it's just slightly displacing the tissues. Stab, grab, aspirate, inject.
Inject.
Yep, and I'm probably going to say, sir, just wiggle your toes while I'm injecting. Or if you're able to, you engage in conversation. What I find is oftentimes students have to concentrate on one skill at a time, but with time, eventually you'll be talking about the garden and the dog and the weather and the kids and going about your tasks all at the same time. Okay, so I've left the site.
So I see you've engaged your safety there.
Yep, never recap a needle. And if in a situation you absolutely have to, it has to be that scoop cap.
Okay.
Yeah, but engage your needle and then dispose of the whole thing into the sharps.
Okay.